I'll have to look it up.
Superpower, if you could pick one.
Definitely Batman.
The one with no superpowers.
The power to be a billionaire.
I mean, think about it. There's a lot of superpower work there.
All right, I like it. Hello, everyone, and welcome to another episode of the Immersive Medical Podcast. On today's episode, we are interviewing Geoffrey Roche. This gentleman is at the executive leadership level in healthcare. He talks about things like the future of work and education and is a top voice in leadership on healthcare. He also got his MBA from the University of Arizona, which is where my hometown is, so yeehaw there. And and he also got an executive certificate from Harvard Medical School on leading digital transformation in healthcare.
He's the Director of Workforce Development at Siemens Healthineers, the Executive Advisor in National Healthcare Practice for Core Education PBC. He's a podcast host for EdUp Health Up, which talks about the healthcare system facing global workforce crises at all levels and roles, and he's the son of a nurse.
Geoffrey Roche is on the Immersive Medical Podcast today to give us that director level, that executive level view of healthcare and the problems and solutions that we all have laid out in front of us. So without further ado, we bring you Geoffrey Roche. Geoffrey Roche, welcome to the Immersive Medical Podcast. Thank you so much for being here today.
Thanks for having me. Good morning.
Good morning. It is morning, isn't it? That's why we're going to say this is coffee. Well, Connor and I are very excited to talk to you. You're quite a leader in this healthcare and would you call it public health space? Because I read a lot about some of the stuff that you're doing. And It seems like a lot of it has to do with health inequities at a large scale.
Very much so, globally, absolutely.
Well, tell our listeners a little bit about what you do. Like, what problems do you work to solve? Like, we can see on your LinkedIn that you're a VP of fanciness. But can you tell us a little bit about some of the challenges you're trying to solve in healthcare?
Yeah. Well, the first thing I want to say is, what you didn't say about my LinkedIn is the first thing it says is that I'm the son of a nurse.
That's true.
So, which is an important element because I always say that a lot of, and not only am I here because of my mom and obviously my dad too, but more importantly, the influence that my mom had on me has led me to do a lot of the work that I do. And so, certainly have been a voice for issues around really advancing health equity because our society here in the United States, but also globally, has systemic, elements that still hold people back from being as healthy as they can be and really having the opportunity to be healthy. But I've also, certainly been very involved in really transforming our healthcare workforce development with a very strong focus on really building pathways and career mobility for everybody. Because, the fact is that if you have resources, you can generally be successful. If you don't have resources in healthcare, it's going to be a lot more difficult. And so how do we create, really systemic solutions that are truly going to be there for everybody? And then certainly I've been involved in social determinants of health and also the political determinants of health because you can't have social if you don't have political. And so very involved in those issues as well.
So you used a lot of very specific terminology that if you're not, for example, social determinants of health. Now let's keep in mind our listeners. Yeah, Connor's like, what? What are you saying? That sounds very fancy. But it's super important stuff. And a lot of these terms are created, these acronyms are created so that way we can try to encompass a very large problem in healthcare. I want to keep in mind that a lot of our listeners, they're just regular nurse, regular paramedics. Some of them are medical students, residents. Some of them are doctors now or NPs now because they've been with Immersive Medical for a couple of years on our YouTube channel. They're trying to be better nurses, better paramedics. So some of this stuff, this systemic, high-level, overarching solution search is kind of out of grasp, right? The problem that we face today is like, I have low wages or I'm burnt out or our emergency department is full and I'm 12-1, which is unsafe as a nurse with my teammate, paramedic, and the doctor. And I want to quit this profession. This is not what I thought it was going to be. Yeah. I'm emotionally exhausted. Now, social determinants of health refers to what the patients are experiencing. And we're all a patient at one time or another. So that does include us. So allow me just for a second to kind of define social determinants of health, which is encompassing 5 major things, we'll call them. Economic stability, education, access, and quality, healthcare access and quality, neighborhood, and your built environment, and then the social community and context. So like if you think of all of those things, they impact your health. Mm-hmm. Who you hang out with, what you spend your money on, where you live, the water you drink, and more than just, that's more like an environmental, but it's an aspect of your social determinants of health and where you spend time socially. Geoffrey, do you have anything to add to this concept of impacting social determinants of health? Did I miss anything?
Yeah, I would just add transportation, obviously, and access to healthy food, and not just expensive healthy food, because, again, if we go back to means and the opportunity to be as healthy as possible, a lot of places in this country don't have access to healthy food. They have access to fast food, but not necessarily healthy food. So I would just add those two as well.
Okay, so if you could do something about, let's pick one of those. Let's pick access to healthy food. But outside of talking about it, and it's okay if talking about it is the solution at our level, but what can we do to help solve some of these social determinants of health or impact them?
Yeah. Well, I mean, there's some phenomenal models that are in place, right now. And one of it is really called partnerships. I mean, you really have to bring together a healthcare system, with other community-based organizations, whether that's EMS, as well as churches, synagogues, schools, et cetera. I mean, if you look at Geisinger, take a phenomenal model, Geisinger, they have what's called a fresh food pharmacy. Phenomenal, nationally recognized model program that's dealing exactly with this issue, where patients have the opportunity, residents have an opportunity in the region that they serve to literally go to a fresh food pharmacy where they can pick up access to fresh food. And again, regardless of their ability to pay, will have that access. And that's really what we're talking about here.
Fresh food pharmacy, that sounds so good. I love the way that you say it like that. Yeah, because food is medicine.
Absolutely.
Right? I mean,
absolutely.
There are people take so many different types of multivitamins and stuff like that. It's like, well, but if you just ate the spinach.
Yeah.
But spinach is expensive. Well, for that matter, so is a Big Mac nowadays.
So this keeps going up in price.
It really does, doesn't it? Okay, so Geoffrey, what would you say are some of the bigger problems that you are trying to solve? And I know earlier you listed quite a few of them, but like if you could pick one or two things in our healthcare system that you'd like to work to solve, what would they be?
Yeah, well, I mean, there's a lot. You'll always hear me say that in many ways, the U.S. healthcare system really needs a significant redo. Because if you go back in time, you have to acknowledge the fact that our U.S. healthcare system was built and established for really privileged white men.
Yes.
That's a real fact. And so when you consider that, it's not unheard of to truly understand why we sit in 2023 and still have maternal mortality rates of developing countries, frankly, worse than some developing countries. And the sheer fact is that systemically, our system wasn't built for that. And we haven't taken the time, years, decades, etc., centuries, to really focus intentionally on fixing that. And so for me, we have to do a true health equity review. We have to ensure that every facet of our healthcare system is truly meeting the needs of every single patient, regardless of their culture, regardless of their heritage, regardless of their ethnicity. It is for them. And that is not the case in the United States as we sit here this very day. And I think all of us should be really discouraged by that. But as I tell people, don't lose hope. We've got to continue to fight, continue to do our work to ensure that that happens. And we're making strides. But that's an example to me that's a very big one, which is why some people will challenge me on this regularly. But I often say we've got to blow it up and start over. because the model is not really there to really move us in a healthy manner because of how it was systemically built.
What do you think, Connor?
Geoffrey, you mentioned that we were making strides to make these changes in the healthcare system. What strides have you, or what strides have you seen in the past, year, 2 years, 3 years that either you've been a part of or you've seen firsthand that are changing this climate of the healthcare system?
Yeah, so there's some definite positives. I mean, if you look at, for example, when the statement of gender orientation was introduced into the electronic medical records, that was a positive because, you now have a system where we're tracking, gender orientation identification within SOGI, which does allow us then to better drill down and share resources and information to different patients. And that's really critical. So, for example, during COVID in some states, particularly states that did it right, i.e. Pennsylvania as an example, where we were under the leadership of Dr. Rachel Levine, who you may know is also now our Assistant Secretary of Health in HHS. Dr. Levine is the top transgender official in the federal government, was also the top official here in Pennsylvania. And when Dr. Rachel Levine was here, we were doing all that work. And that's a critical step. But I'll tell you, there's others too. I mean, I think, when you look at the work we're doing in population health to really advance having, tangible initiatives and efforts to better meet the needs of various different patient populations, that is definitely the step in the right direction. The fact that we're actually training the healthcare workforce in issues of not just cultural competence. And Devin will remember this because most people that have been clinical at some point have been trained in cultural competence. Cultural competence is not enough. We're really talking about coaching individuals to understand and demonstrate empathy to one another and be able to meet their needs regardless of who they are, where they came from, their religion, their culture, etc. And so that's a very different thing than cultural competence. This is really the idea of we're getting to know you for who you are, and we're going to meet your needs for that very notion. And so we're making a lot of work, and I'll give kudos to some systems too. I mean, if you look at the work coming out of Common Spirit Health under the leadership of Dr. Alicia Jackson, I tell people all the time, if you want to look at a champion physician who also almost lost her own children to maternal mortality, she's public about that, like Serena Williams. Dr. Jackson is leading population health work, also called the Human Kindness Healthcare Project at Common Spirit, doing phenomenal work to advance this. And that's the type of stuff that I'm encouraged by. But we've got to do more of it.
I'd like to give you an example of something I experienced on the front line working in the emergency department that I think speaks to exactly what you're talking about. Now, I want to warn our listeners that this is a medical story that I'm going to tell, and it's a little bit sad. So and no one passed away, so everyone lives. But it speaks to exactly what you're talking about right now, at least on some level. So we get a person who walks in to the emergency department through the front doors, and they're bleeding. They're bleeding in their pants. And they walk up, and we immediately put them on a bed, get them in, and take them back. What we discover is that this person, who was transgender, had a gunshot wound to their crotch. And they turned out okay. We stabilized them and transported them to the level 1 trauma center in our city. The problem is how they arrived at the emergency department. This person was dropped off at the front door by the police department. And they were not brought in by the police department. Mm-hmm. I want to be clear. They were set in presumably a wheelchair or a chair or a bench outside. And this person made their way in. That's a real challenge. If for nothing else, the individuals, and I want to say something else. This was about 8 years ago. Okay, a lot has changed socially today, for the better and for the worse. I mean, we are certainly as a country heading in some directions. But there's certainly a lot more visibility to this type of thing. I think if that happened today, there'd be some serious repercussions for making those types of decisions. I'd like to think so.
Probably depends on the state that you're in, but
probably depends on the state that you're in. At the same time, I kind of have a little bit of, I feel bad for the individuals who had an education gap, who picked up this person who had been shot in the crotch and were scared or confused or just didn't want to check because of how they felt when they encountered a transgender person. And I think that was a real problem for that individual. And that, in my opinion, could have been any one of us. Mm-hmm. Because at the end of the day, you're just a person. And you go into that emergency department, and that physician needs to treat your physiology to get you out of the hospital better than when you came in. We can't do that if we don't know what's going on underneath your skin, mm-hmm. which is why we need venous access, which is why we need to get IVs in you so we can give you the right medicine. Your veins don't have a gender, right? we need to treat your physiology. I just wanted to tell that story really quick because it's a very specific example of a facet of what you're talking about. And because right here, between the three of us in this podcast right now, one of us has had a specific encounter with this problem, we could probably easily just look at this and go, okay, so maybe that's 30% of the country is experiencing this right now, still today. We're just a little microcosm of the world, right? Yeah. I mean, I'm making up statistics about that, but what I'm trying to say is that this is happening every single day. I think it's a real problem.
Yeah, it is. And you know, similar to maternal mortality, which is happening every day too. You know,
absolutely.
If you think about it statistically, the fact that a Black African-American mom goes into OBGYN practice, still offered the same level of, let's hope they're offered the same level of prenatal care. You know, we know that's not necessarily happening. And then, is predisposed within our system to potentially lose their own life or lose their baby's life just because of the color of their skin is very real. And yet, we don't, we're seeing acknowledgement of it in the healthcare system, but we're not seeing a full acknowledgement as a country is really interesting. And it gets back to some of those systemic, type of situations. And we've got to move forward because literally lives are on the line on both ends.
Absolutely. Yeah. Well, speaking of lives on the line, the WHO posted some numbers here that I think are going to speak to you, Geoffrey, because it covers this big public health crisis and trying to solve these problems. So I'm going to read you a little statistic, and I'd love to get your thoughts and reactions about how can we actually attack this, because I'm not sure if people really understand just how big of a problem this is. So we've got some staffing shortages in healthcare, and it's happening around the world. Maybe we don't need to solve all of the world's problems, but if we could try to solve our problems at home, that would be really good. So the U.S. is not the only country to suffer. And by the way, I'm reading an article. I want to cite them right now from the Keck School of Medicine of USC right now. And this is published March 13th, 2023. The U.S. is not the only country to suffer from a staffing shortage of healthcare workers. The World Health Organization predicts a shortfall of 15 million healthcare workers worldwide by 2030. That's in 7 years.
Oh, my God.
The International Center on Nursing Migration Projects, according to the International Center, there will be a shortage of 13 million nurses alone by 2030. And that's up from 6 million, which is right before the pandemic. Think about that for a second. It's 2023 right now. In 3 years, we doubled the number of people that we're going to be short to help treat our population. The reason why this really freaks me out, and I'm looking for the statistics right now, is that here it is, the U.S. Census Bureau. So take that information, right, and now put it up against this. The U.S. Census Bureau reports that 16.8% of the population was aged 65 or older in 2021. And it predicts that number will grow to 21% in 2030. We all know older people require more care, whether in hospitals or nursing homes. So they're more likely to have chronic illnesses like diabetes, arthritis, heart disease, things that nurses care for. So now what do we have? And let me get your reaction to that, Geoffrey. What do you think?
Oh, I think it's actually worse than they actually know. Because I think if you would go into every facet of our healthcare ecosystem today, not just the level of burnout, but the level of frustration with the culture that exists, the practice, the standards of care, the concern around issues of patient safety. I mean, you have nurses on the front lines, to your earlier point, who truly feel they're risking their license, which is frankly part of their DNA. It's what they studied so hard, passed an NCLEX, which we know is never easy to do, achieve that, and then they're on the front lines, and they're feeling that they're not only risking the lives of their risking their license, but also the lives of patients. And so I think it's actually significantly worse. I mean, if you look at, there was data released last week that looked just at the United States and, specifically highlighted that during the pandemic, we lost 100,000 registered nurses. And when those nurses were asked, why did you leave? They said stress, burnout, as well as just overall retirements. But we also know that by 2027, we're expecting to lose another 600,000 plus. But the reality of it is those numbers are always greater than they are, because if you lose a colleague that you're close to, generally there's a good chance you're probably going to look for something else as well. And so I think there's a lot that we can take from that. One of which is you got to change the models of care. You can't have the same model of care that has existed in pretty much every single facet of our healthcare system in the inpatient space for all these years. There's not a lot of differences if you look at it. We've been practicing the same way forever. If you look at 1960, the way nurses practiced in 1960 to 2023, it's pretty much similar. And so we've got to actually listen to them. The first thing I say to fellow leaders is go out and ask them what they want. Go authentically listen to them. Intentionally ask them.
Yeah.
What would make you a happier nurse? What would make you a happier medical assistant? Because here's what we're also not really seeing in these statistics is we're not seeing the impact on the allied health professions. We're not seeing the impact on EMS.
I'm so glad you said that.
So guess what? Those numbers are also staggering. And I will be the first to say those numbers are actually probably worse because we haven't increased the pay substantially as we have in nursing. Now, I'll be the first to say nurses are not paid enough. Yes, travel nurses make a lot more than a traditional nurse, but across the board, we have a lot of work to do in creating equity in pay within our healthcare ecosystem. And so there's a lot of things we've got to do, but we've also got to address culture.
And I want to acknowledge for our listeners right now that the pandemic is a fluke. Okay, the pandemic is an outlier on the bell curve for travel nurse wages. This is not the norm. Yep. And because I can hear people right now saying, "What are you talking about? There are nurses that are quitting all over the place, and travel nurses making $60, $100 an hour. They're killing the game. They're going all over." It's like, okay, wait, stop. That's good for now. Okay, fine. I'm glad that there are some nurses that are really making a good wage. It doesn't help the nurses that are staying at those hospitals. They're not getting a raise. So now you have a more seasoned, more experienced nurse who's institutional at your hospital, and then you have a younger nurse come in travel making double what they're making because the hospital, why?
Yeah.
Because the hospital needed more nurses. They're short-staffed, and rather than increasing the pay of the people who are there, they double or triple. They pay agency fees. I mean, it's extremely expensive to have a travel nurse.
Mm-hmm.
And there's even if
balance. even if that nurse becomes a huge asset for your nursing team, they're out of there in 3 months or 6 months or however long their rotation is. They're going to another hospital, do the same thing over and over again. So you're constantly losing those assets.
And you're incentivizing the institutional nurses to leave.
Yeah.
Yeah, absolutely.
And the other thing you have to look at, I mean, and there have been some studies that correlate this. And again, to your point, Devin, look, we did need travel nurses during the pandemic. Yeah. Don't get me wrong. But systems that have paid attention to this have noticed that, and it makes total sense. When you have a care team that lives in your community, serves your community, your patient safety scores are higher because they treat them as if they're family. When you are a travel nurse, you don't necessarily have that same level of connection to the profession, same level of connection to the patients and the community that you serve. I'm not sitting here and saying they're a bad nurse, because that's not what I'm saying. What I'm simply saying is the connection isn't there. And so, they don't tend to understand the social determinants of health that may exist within that region. They don't necessarily understand, the housing situations, the transportation, all those things that we talked about. And so, look, at the end of the day, we needed them. Don't get me wrong, but we have a lot of work to do to really not be in a situation where this happens again. Yeah. And here we sit, a couple of years out of really the heat of the pandemic, and we are still using a lot of agency.
We still need them. Absolutely. And unfortunately, the pandemic just proved that the hospitals are willing to pay when they're in a pinch.
Yep.
Yeah.
which is a real challenge for the people who stayed. It's like, so you are willing to pay, just not for me.
Yep.
That's a challenge.
Check out their margins now.
Yes. Yeah. Absolutely. Okay, let's talk VR patients. Now, these folks, they're not just creating a VR platform. They're revolutionizing medical training. So picture this. You're anywhere in the world, and you just log onto a VR patient's account. Strap on your VR headset, or pull up your web browser, and boom, you're in the middle of a high-stakes medical scenario. Sounds like sci-fi, right? But it's as real as it gets. It's like having a futuristic healthcare classroom right in your pocket. Check it out for yourself at vrpatients.com. That's vrpatients.com. Trust me, it's worth a look. I actually recently heard a statistic about 90 to 105,000 post-surgical, what am I trying to say? 90 to 100,000 people every single day are like coming out of some sort of new surgery in the United States. So like they're getting a PEG tube, or they're just getting some the doctors are doing these surgeries quickly, right? And the percentage of them that are ending up as a post-surgical readmit because they get an infection and then they go back into the emergency department and go, I think this is infected. And then the people in the emergency department are like, what are you doing in here? Get out of here. We're full of SARS, CoV. We've got RSV, flu season. Go back to your house, right? And the person's like, I'm scared. I just had surgery the other day. And they go, yeah, you're immunocompromised. Go home. Like, I need to be seen. This doesn't seem right. I'm not a doctor. You sent me home with a new PEG tube. So then they get seen. Doctor's like, you're okay. Let me send you home with some painkillers. And they go home. And then they come back to the emergency department 3 days later with RSV, because guess where they got it? Yep. And now they have to be there. And the hospital doesn't get reimbursed for that.
Yeah.
So you were talking about margins, and there's an incentive to keep people from coming back into the hospital. That's just a straight margin reason.
Mm-hmm.
It's also a health reason.
Mm-hmm.
So
frankly, that's a terrifying cycle.
It is. Tell me what you mean, Connor.
It seems like there's no winning there. The hospital's
there's winning. But are they doing it? You're right. And I think this is part of what we want to talk about here. Like, what is the solution? If we were just to attack that small problem, which is a big problem, but it's small in the grand scheme of things, it's got to be some form of remote virtual education for the person who gets discharged from surgery, so they don't come back in, but they have a sufficient level of education that shows them, trains them, teaches them how to care for their own wound, and some remote interface with their physician so they can ask questions, or their care team, right? However, the care team's burnt out, they're overworked. All of those remote solutions cost money. And if only we lived in a time where we were forced to become remote and it became a norm for a little while. So everyone got used to the screen, right? to kind of help advance technology a little bit during this time of crisis. Because I'll tell you what, if the pandemic would have hit in 1980 this bad, whew, it would have been a different story, guys.
But I mean, right? There are solutions to counter what you're speaking to, and these are solutions that are in place, throughout this country, from really innovative healthcare systems. Solutions like using community paramedicine. Mm-hmm. You've got paramedics who, are not always necessarily on, urgent calls, who can be paid to operate at their license and help take care of the community. And, we've got phenomenal on it. I mean, UPMC has had this program in place for many years. You have many systems in more rural communities using this program. Phenomenal results. Because, again, community-based care matters, and community-based care moves the needle when it comes to quality. So we have some great, solutions in these areas. Again, though, you have to be able to think outside the box. And in healthcare, you can't let the risks hold you back. I was at a system where we deployed this very model. We also deployed a model called a health coaches program, where we launched it with a university. And again, if we would have let risk be in the way, we would have never launched it. But that program was phenomenal, still in place today. Has students getting trained, going into the homes of patients. We reduced readmissions. We improved quality on issues like COPD and congestive heart failure. There's a lot of good work in this space, but here's the kicker. Is it reimbursed? No. And so if the system does it, they're doing it for the right reason. If they don't, it's because they don't want to do it because it's not reimbursable.
And who's going to bear the cost of that burden? The burden of that cost. Sorry, I was backwards.
Well, in our model, we were doing it because we knew that either way it was going to end up being uncompensated care. Now, the sheer fact is we went out, worked with payers, and got payer funded type of projects to be able to do it. But the fact of the matter is many are not going to do that.
Geoffrey, quick question for you. What do you mean exactly by define community paramedicine?
Great question, right? A lot of our listeners may not know paramedics are in the community. So what do you mean?
Yeah. So, I mean, if you look, let me say, if there's one aspect of our healthcare ecosystem that most people don't always realize until they have to call 911, that are the true, angels in serving the community, it's EMS. So, our EMTs and paramedics that are literally, there when you call 911 tend to be, in the community. We will see them at a Dunkin' Donuts. We'll see them at a diner. We'll see them in the grocery store. We'll see them at football games in the community. We'll see them at sports games. And they're there when we need them most. But here's the fact. They are also certified, credentialed, trained healthcare professionals. And they can operate at their license too. And they save lives as they do every day. But they can also improve lives as they do every day. And so if you think about it, if you're in a community and you have what we call a 911 agency, whether it's an EMS agency or sometimes they're with fire, combined in the urban environment, they are there in the community. They have their stations that they may stay at when they're not on calls. But, the model here is you use them when they're not on calls, and you create a model where, some of the EMTs, paramedics may actually, to Devin's point about other care team members, they may not want to just go on 911 calls anymore. Talk about a model that creates a sustainable workforce. Because if you look at the number of paramedics that go on to be a nurse, it's actually pretty high. If you create a model where they're doing things that prepare them, you have a greater chance of getting them to move on and become a nurse or go on and become something else. And so this is a great program that has been used in urban, suburban, and rural communities where basically what happens is you discharge a patient with, say, congestive heart failure or COPD or another super utilizer type of condition. And as part of that discharge, you bring a paramedic or an EMT in to meet with them. They build rapport and what we would call a handoff, a reverse handoff in this case. They go home, and actually in this case, if a family member is not there, the paramedic EMT take them home, not in an ambulance unless they need it, but in another type of a vehicle. That paramedic EMT team meet with them. They check in on them. Instead of calling the 911 agency or calling their doctor, they actually call them. There's an EMR connection where they're transferring everything back to the health system. And what happens is they build such a rapport. I'll give you an example. We had in our system case where doctors, nurses were working with this patient on and on, couldn't understand what was going on. Did they ever go to the home? No. But the EMS team went to the home and they were using salt. As simple as that. Using salt when they were told not to use salt. And when the EMS team said to them, "You were told not to," they said, "Well, I didn't really understand. I thought I could use a little bit." They said, no, you can't use any. And guess what? They stopped. Right. In fact, EMS took every salt in that entire place, got rid of it, and that patient still loved them because they built a rapport. They saw them as the community servants that they were, taking care of them. And instead of taking them on an ambulance, they were keeping them at home healthy. And that was the difference.
The only challenge with community pairs. Go ahead, Connor.
I was just going to say, it's a little bit more of like a neighbor helping neighbor situation as opposed to like professional helping patient.
It's a beautiful idea. The challenge I see with it, it's just not scalable. You hit limits. Staffing shortages is what we've been talking about, right? We are going to have millions of people that we need to hire. So I agree. Community paramedicine, I think that should be happening more frequently all over the country. It's got to be one piece of the puzzle. All right, so I want to be mindful of our time. We are running out of time, and we have two sections that we want to do with you, Geoffrey. One of them is just the lightning round, and we're not going to give you any hints or anything. We're just going to ask you some fun personal questions, off the top of your head, like your favorite color. But I did something fun for you that I think our audience might enjoy. We've never done this before, but since we were talking about public health and the crisis, and then also the fact that it's 2023 and we've got some pretty significant artificial intelligence models that have just exploded, I thought, why not ask AI and see what it thinks? So since we have a leader in, I would call you a leader in public health, a leader in education public health, someone who's a strong voice, I'm very interested in what you think AI thinks is the solution. So what I did was I told the AI model to read some articles that were published about the WHO, the WHO's predictions, and gave some stats and the looming crisis and dates and all of that. And it's going to take its knowledge up to 2021 and then add this on top of it. And then I said, I want you to act as an expert in the fields of the federal government, HHS, the Congress. I want you to act as an expert in Congress, state governments for local policies, the private sector, like hospitals, and then advocacy groups, American Medical Association, American Hospital Association, CDC, FDA, Medicare and Medicaid services, right? So it's got this list of like, I need you to be an expert in these things. These are the bodies that create and change policy in healthcare in our country. Okay? I want you to read this article, act as an expert, and tell me what you think the solution is. Now, we're going to make a quick statement here, folks. This is just GPT-4, all right? It's a language model. This is not the solution, but maybe it'll say something interesting, and maybe it'll help us come up with some ideas. So let's just go with that.
Started.
Let's get the conversation. Yeah, it's already started, but maybe this is going to say something that no one's thinking of. So it gave some strategies. And I'm not going to read the details of every single one because I asked it to refine and say, well, but what do you think will actually work? So it first gave me some strategies to address the issues. It said short-term strategies, customize recruitment and retention, competitive salaries, signing bonuses. Okay, good idea. Engagement and job satisfaction. Create opportunities for healthcare workers to be heard, to do their best, feel a sense of ownership and independence. Okay, cool. Scheduling. Utilize advanced scheduling tools like AI. It's suggesting use itself. That's pretty good. And allow staff to shift appropriately and avoid overworking, right, for that exhaustion. Long-term strategies. Investment in public health. So we got to increase public spending on health programs. Okay. Nurse practitioners. I like this one. Allow nurse practitioners to have the full practice authority to help alleviate shortages in the healthcare. I like that for PCP. Diversity and equity. I think this is partly your wheelhouse, right, Geoffrey? Mm-hmm. Recruit more minorities to become healthcare workers as professionals who share a cultural background with patients that can improve the quality of health care. Then there's telemedicine. I think that's happening for sure, especially in mental health. Real great expansions over the last few years for mental health remotely. Expand the use of telemedicine, allowing people to live and access healthcare services more easily. Address nursing faculty shortage. I like this one. Mm-hmm. Increase the pay for faculty to attract qualified professors, and then collaborate with colleges, universities, and healthcare providers to ensure more students enroll in nursing programs and then complete them.
Yeah.
Education and training. This is 2 for education. Invest in healthcare workforce training, especially in low-income countries, and address nursing faculty shortage in the United States, which constrains the number of students who can enroll in training programs. Deployment of healthcare providers in remote and underserved areas, and then international migration, address the issue of healthcare workers emigrating from their home countries for better compensation and financial opportunities. So it gave me all of that. I was like, wow, those are really broad. If you could pick ones that you think would have the largest impact, what would they be? And it gave me 4. Increase funding for nurse and medical schools to allow for more faculty positions, better resources, and larger class sizes. Mm-hmm. We all know that the schools are just cycle applying for grants. And COVID relief funds, they end in 2024, guys, if you haven't spent that money, which means all of these schools that are using COVID relief funds to expand and purchase remote solutions, the funding's not going to be there going forward. Offer scholarships and incentives to attract more diverse range of students. That is 2 for education, particularly those from underrepresented backgrounds to pursue healthcare careers. Number 3, expand and promote educational programs that focus on geriatrics and gerontology to better prepare healthcare workers for the needs of the aging population. That is 3 for education. Number 4, encourage partnerships between healthcare providers and educational institutions and government agencies to create more clinical training opportunities to better align education and workforce demands. Look, I read that for the first time right now after I hit enter, and then we started the pod, and I didn't go back to read it until just now. After it gave us that laundry list of short-term and long-term solutions, the top 4 revolve around education and training. If that alone isn't a wake-up call a little bit, that AI, with all of its collective knowledge and an understanding of where we are today, still thinks we should be investing in education and training. I don't know. What do you think, Geoffrey?
Yeah, I mean, I think without question, that oftentimes, when we make reductions in healthcare, it really is in the areas of education, training, and professional and leadership development. If you look at where our investments are at in a system today, you'll see that they generally are not that large from a budget perspective. And I think if there's one thing that the last few years where we sit today have taught us is that, as we all know, education is powerful, particularly if it's developed, designed, customized for the learner. And if we focus intentionally on it, we can create a sustainable workforce. If we create a model that's scalable, to your earlier point, and really invest in people. Look at the work Guild's doing. I mean, Guild is doing some fantastic work with healthcare, really seeing significant evolution when it comes to career mobility. And, career mobility equals equity. If you really have a career mobility plan in place that helps a learner and a future worker, clinical or non-clinical, be able to grow in their career, we're going to create more equity in the system. And so, yeah, I'm not shocked 100% by that. I think what I'm shocked by is that we haven't necessarily been as intentional within the system to change it.
Yeah. Geoffrey, I want to be mindful of our time. You've given us a wonderful conversation today. We usually end with a lightning round. So this doesn't take long, just a few seconds. Connor, you want to kick it off and we'll go back and forth?
Geoffrey, what is your favorite color?
Blue.
What's your favorite way to unwind after work?
Way to unwind? Hang out with my boys.
Nice.
It's a good one. Favorite book?
Favorite book? Oh my. There's so many. I mean, most recent, I would say the book Workquake by Steve Cadigan is my favorite.
Cool.
I'll have to look it up.
Superpower, if you could pick one.
Definitely Batman.
The one with no superpowers.
The power to be a billionaire.
I mean, think about it. There's a lot of superpower work there.
All right, I like it.
I agree. Where would you travel to given the opportunity if you could go anywhere in the world?
Anywhere in the world. Probably Australia and New Zealand.
Nice. Let me know how big the spiders are. If you could have dinner with a historical figure.
Historical figure. Living or not living?
Doesn't matter.
Martin Luther King Jr.
Cool.
Do you have any pets?
One dog.
Coffee or tea?
Coffee.
Favorite sports team?
Eagles.
If you could have any job other than that one hurt. That one hurt Connor.
Is Connor a Cowboys fan?
I'm not a Cowboys fan. I'm a Packers fan, but I just can't.
Pennsylvania. Go Pack, go.
You don't have much to cheer for, so.
Not anymore. We don't. I don't want to bring it up, though.
We do in the Eagles side.
I'm going to be moving to Cincinnati one of these days pretty soon, so I'm going to have to become a Bengals fan, and that's going to be tough.
We are a big Joey B household, though, I will say.
All right, if you could have any job other than your current one.
President of the United States.
Nice. Okay,
that's a new one. I haven't heard that one.
Yeah, that's a great one.
Closing question, advice, if you were to give advice to a new student going through the healthcare system now, or healthcare education system, what would be the number one piece of advice you'd give?
I would say make sure you have passion and a whole lot of perseverance.
Geoffrey, it's been amazing speaking to you. I hope to do it again. Everyone needs to go and check out his podcast, the Ed Up Health Up podcast. Recently, you just did an episode about some public health issues, and I think everyone should go check that out. We'll put his link to his information in the show notes in the description. Until then, we'll see you later. Hey, Connor, are you finding it challenging to organize asynchronous clinical education for all your students?
Devin, I don't have any students.
Well, that's okay, because no matter the class size, from 10 to 10,000 students, we have the perfect solution for you.
VR Patients isn't just a virtual reality platform. It's an asynchronous learning tool, which means students can access it anywhere, anytime.
Exactly. They can jump into a VR simulation from their VR headset or even from their web browser. Clinical competency training doesn't have to be confined to a specific schedule or location anymore.
To learn more about how VR Patients can make learning more accessible and scalable, head over to vrpatients.com. That's vrpatients.com.
And if you don't have any students just like Connor, but you do have a VR headset, you can try it right now for free on the MetaQuest Store or Steam.